Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites viewmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the parathyroid gland. The parathyroid glands are situated on the posterior aspect of the thyroid gland in its substance or in the sheath of the gland and in relation to the upper cornu of the thymus. The glands are usually 4 in number, each measuring about 5 millimeters in diameter. Functions: it controls the concentration of calcium and inorganic phosphorus in the blood plasma, both by enhancing the removal of minerals from the bones and by promoting the excretion of phosphorus by kidney. It is the ionized plasma calcium concentration which is important in view of tetany. When the plasma protein concentration is high, the plasma calcium concentration which is important in view of when the plasma protein concentration is high, the plasma calcium might be 12 milligrams per 100 ml or even more, but it would not be necessarily constitute evidence of hyperparathyroidism. Hyperparathyroidism. It is described as the excess secretion of parathyroid hormone due to primary disease in the gland or secondary to renal disease. Primary hyperthyroidism. It is rare and may be due to single adenoma of the gland. Multiple adenoma or functioning parathyroid carcinoma are also possible. Secondary parathyroidism. It is found in chronic renal failure. It also occurs as a sequelae to osteomalacia associated with malabsorption syndrome, etc. Tertiary hyperparathyroidism. The secondary type of long-standing in which the continued stimuli is responsible for parathyroid hyperplasia being replaced by autonomous function in one or more parathyroid adenomas. Osteitis fibrosa or VONRECKLINGHAUSEN'S disease of bone. When the condition involves the bone to such an extent that cyst formation occurs. Clinical features: polyuria and thirst may be sufficiently severe to suggest diabetes insipidus. Weakness, loss of appetite, drowsiness, nausea and vomiting may be present. Backache. Epigastric pain due to simultaneous peptic ulcer and pancreatitis. A swelling in the region of thyroid gland may be present. Diagnosis: raised plasma calcium concentration, and it is important to carry out a series of estimations at intervals in doubtful cases, as it is episodic. Tourniquet should not be used to collect blood sample as it may increase the plasma calcium. Radioimmunoassay. Parathyroid hormone. It is valuable in localizing small tumors by identifying high concentration of hormone in specific veins in the root of the neck or mediastinum. Negative assay does not exclude the tumor. The parathyroid adenomas may coexist with secreting adenomas in the pituitary, pancreas or elsewhere. In case of unusual symptoms, it may be considered. Differential diagnosis. Hyperparathyroidism can be differentiated from other conditions by the presence of hypercalcemia and hypercalciuria. Immobilization, metastatic malignant disease of the bone, Paget's disease of bone, sarcoidosis, overdosage of vitamin D, myelomatosis. Treatment. Kidney functions are studied to know if there is any advanced renal disease. In absence of it, simple removal of the solitary adenoma is sufficient to produce a clinical cure. Patients with multiple adenomas or generalized hyperplasia of all the parathyroids may be difficult to manage, especially when the gland lie in unusual situations as superior mediastinum, but surgical treatment offers the only prospect of amelioration. The next is hypoparathyroidism. Hypoparathyroidism is defined as the condition in which there is a decreased concentration of calcium in plasma and increased concentration of phosphorus in plasma, and causes tetany. Due to these changes, there are many conditions causing this condition. Post-operative hypothyroidism. It is a transitory form of disease due to partial thyroidectomy resulted by the interpretation of blood supply to the gland. After a complete thyroidectomy, maybe for carcinoma, permanent hypoparathyroidism may occur. After removal of parathyroid adenoma or carcinoma, it may occur partly on the extent of biopsies of the tissues have been undertaken. The degree of hypocalcemia is largely determined by the severity of the accompanying bone disease. Infantile hypoparathyroidism. It may be transient and may be due to maternal hypoparathyroidism or calcium deficiency, or may be due to thymic aplasia. D-George syndrome. Idiopathic hypoparathyroidism. It may occur at any age, may be associated with autoimmune additions disease, thyroid disease, or premature ovarian failure. Antibodies to parathyroid, adrenal and thyroid tissues have been demonstrated in some of these patients. So autoimmunity is a probable cause. In these patients, in addition to tetany, there may be psychosis, cataract, papilledema, calcification in the basal ganglion, and moniliopathy, particularly of fingernails. Familial causes have been described. Pseudo hypoparathyroidism. It is a congenital variety and familial in nature. In addition to biochemical changes, may present calcification or ossification, cataract, mental retardation, and skeletal abnormalities like short metacarpals. These patients are resistant to administration of parathyroid hormone. Their parathyroid is normal histologically, and high concentration of calcitonin have been found in their circulation and in their thyroid glands. Treatment. Synthetic preparations of parathyroid hormone available for the treatment of parathyroid insufficiency or unsatisfactory, as they are to be given frequent injections and soon become ineffective because of antibody formation. In the acute phase, calcium is given intravenously as for tetany. For persistent hypoparathyroidism, substitution therapy is used with calciferol or an analog of vitamin D. Dihydrotachisterol. Tetany definition. Tetany is described as increased excitability of the nerves due to the reduction of in the concentration of ionized calcium in the plasma and may be accompanied by paresthesia, intermittent spasm of the muscles, usually affecting hands and feet. Etiology. There are two factors responsible: low plasma calcium and alkalosis. Magnesium depletion also to be considered as a possible contribution factor in the malabsorption syndrome. Causes of calcium depletion: inadequate intake or absorption, calcium rickets, osteomalacia or malabsorption syndrome. Parathyroid deficiency, chronic renal failure. In this condition, though plasma calcium is low, coincident acidosis usually prevents the appearance of tetany. Conditions associated with alkalosis. In alkalosis, the proportion of plasma calcium in the ionized form may be decreased. Though the total calcium remains unaltered, such a change may lead to tetany. The causes of alkalosis are repeated vomiting of acid gastric juice, as in pyloric stenosis. Carcinoma of stomach. Excessive quantities of absorbable alkalis due by mouth and also associated with repeated vomiting. Hyperventilation, which is most commonly due to hysteria or some emotional disturbance. Overbreathing lowers the alveolar carbon dioxide concentration and consequently the plasma carbon dioxide tension. Some cases of primary aldosteronism. Clinical manifestations of tetany. In children, a trial of carpopedal spasm, laryngismus stridulus and convulsions may occur, though one or more of these may be found independently. The hands in carpal spasm adopt a characteristic position. The metacarpophalangeal joints are flexed and the interphalangeal joints are extended. Pedal spasm is much less frequent. Laryngismus stridulus is caused by the spasm of the glottis. In adults, carpopedal spasm is the usual finding. Patient complains of painful cramps in the limbs and tingling in the hands and feet. Latent tetany. Here the signs of spontaneous carpopedal spasms are absent. It is recognized by eliciting the following signs. Trouse's sign: inflation of the sphygmomanometer cuff on the upper arm to more than the systolic pressure is followed by characteristic spasm in the forearm muscles within 4 minutes. Chvostek's sign: a tap over the facial nerve in the parotid gland stimulates the hyper-excitable nerve and the facial muscles contract. Treatment: control of tetany. Injection of 20 ml of a 10% solution of calcium gluconate slowly into a vein will raise the plasma calcium concentration immediately. An intramuscular injection of 10 ml may also be given to obtain a prolonged effect. In alkalotic tetany, the plasma calcium concentration is normal, but the ionized calcium is reduced. In severe cases, intravenous calcium gluconate often relieves the spasm, while more radical treatment of the alkalosis, which will vary with the cause, it is being applied. In persistent vomiting, intravenous saline is the most effective treatment. When alkali have been given to excess, their withdrawal may suffice to stop the tetany. But if not, ammonium chloride 2 grams should be given 4 hourly until the relief has been obtained. The inhalation of 5% carbon dioxide in oxygen may be prescribed for the correction of the alkalosis of hyperventilation, or more simply, the patient may be made to rebreathe her own expired air from a suitable bag. If the patient is then asked to overbreathe until tingling is again felt in the fingers, she is so impressed by the demonstration of the origin of symptoms that this sequence of events does not occur. The hysterical patient should be treated by appropriate psychotherapy. If not relieved by giving calcium, the administration of magnesium may be required. Treatment of the underlying condition, rickets and osteomalacia. These are treated accordingly. Malabsorption syndrome. It is corrected by suitable measures. Chronic renal failure. In this condition, temporary benefit is usually by parenteral calcium is the most that can be expected unless hemodialysis or transplantation is being employed. When tetany is due to the removal of the parathyroid, and if there is any residual parathyroid tissue, it usually undergoes compensatory hypertrophy. In the interval, intravenous calcium gluconate may be required to control the tetany. If no tissue is left, prolonged replacement therapy with calciferol is commonly used to maintain a normal plasma calcium concentration. One tablet 1.25 milligrams daily is usually adequate. The maintenance dose is determined by the careful monitoring of the plasma calcium at regular intervals, as persistent hypercalcemia, which might follow prolonged high dose of vitamin D, would lead to widespread metastatic calcification and rapidly progress renal failure. Dihydrotachisterol is another analog of vitamin D, but is expensive. That's all about the parathyroid gland, and in the next video I will discuss about some other disease. Thank you.